We're going to do everything in our power to start on time and take our breaks on time and have just a wonderful, productive, and informative and community-building day. So we're going to do more proper introductions at 10 o'clock. Many of you, and the room is quite full, are here for the first time. Based on our early registrations, about 40% of our crowd today, and maybe even more, will be at their first conference. So we have a lot of newly diagnosed people in the room, and we're going to spend the initial period here in the first half hour doing a primer, which, quite frankly, I'm staying for because I think all of us learn so much from people like Pam Kunz and Josh Mailman every time we hear them. So I'm just going to say a couple of things right now, and then we'll do some more introductions in a little bit. Number one, the hat is for the Super Bowl. I promise not to wear it for the rest of the day, but I just beg your indulgence. We're from Boston, and you please don't boo or cheer or anything, but I couldn't resist. I just had to at least get my Super Bowl fix out of the way early. If you could please silence your phones. I'm usually the one who's embarrassed by having my phone ring in the middle of the session, but that would be helpful. And even in the early sessions, you may have some questions that aren't answered in this first half hour or throughout the morning. So on your table are cards. They look like this. You got a question, jot it on down. We're going to try to pick them up during the breaks. And then we're going to have a Q&A at the end of the morning session and a Q&A later in the day. And as I said, we'll do a little bit more introduction in about 25 minutes. But first, let me introduce our wonderful leader here at Stanford and the designer and my wonderful partner in putting this program together, Dr. Pamela Kunz. Pam?
Thank you so much, Ron. So I'm going to wait for the slides. Great. So welcome. We are going to start. I think some people will continue filtering in. The official program starts at 10, but we thought we would jumpstart the day with a primer, sort of an introduction to the basics of NETS. Okay, great. Thank you. So we are going to talk about this new language that suddenly you've been expected to learn, how to understand your pathology, why primary site matters, understanding stage, and then talking a little bit about hormones and functional NETs. So, the NET dictionary. I'm not going to go through all of these words. This isn't, by the way, these slides will be available afterwards, likely on the NorCal, Carcinet, and probably NETRF websites. But there are a lot of abbreviations, acronyms, brand new terminology. And we can reference back to some of these things throughout the day, but this will be available for future reference. So what's in a name? So the word carcinoid is often used interchangeably with the word neuroendocrine tumor. Carcinoid actually came first, and it's derived from a German word, carcinoid, that was coined by a German pathologist back in the early 1900s and meant cancer-like. So in fact, back in the day, these weren't even thought to be cancers. This pathologist, Dr. Oberndorfer, thought these were small and had multiple foci, were undifferentiated, had well-defined borders, had no metastatic potential, and were slow-growing and harmless. And for decades, in fact, close to 100 years, this was perpetuated, and in fact, cancer registrars in hospitals didn't recognize these as being cancers. We now know, in fact, these are cancers, and the word carcinoid is falling out of favor, and we'll talk a little bit about what the new terminology or new preferred terminology is. So there are too many names for describing neuroendocrine tumors. Some of these are older. I'll go through them in case you've come across them in the past. We sometimes describe them as carcinoid versus pancreatic, or by how fast they grow, well versus poorly differentiated, or whether they secrete hormones, so functional secrete hormones and non-functional do not, or named by the hormone that they actually secrete, like an insulinoma that secretes insulin, or a glucagonoma that secretes glucagon. Occasionally, they're also classified by where they originated embryologically, so foregut, midgut, and hindgut. So the foregut includes lungs and stomach, the midgut includes the small intestine, appendix, and the beginning of the large intestine, and the hindgut includes the large intestine and the rectum. So moving on from that, then the World Health Organization has their own classification system. What I'm going to focus on, and you can see this has evolved over the years, I'd like you to pay attention to the 2010 classification, which is really what most neuroendocrine experts and pathologists now use. So neuroendocrine tumor is really the preferred terminology, and then we say of what primary site. So neuroendocrine tumor of the pancreas, or neuroendocrine tumor of the lung. They fall into 3 grades, grade 1, grade 2, and grade 3, and we'll talk about that in just a moment. So the name derives from the biology. So people always ask, where did the word neuroendocrine come from? So neuro, because they can be stimulated by nerves, and endocrine, because they can release hormones. A little bit more on net biology. So think back to your high school biology. So there are protein receptors that are on the surface of the cell, and neuroendocrine tumors have a characteristic receptor called a somatostatin receptor, or SSTR for short. That's one of the abbreviations in the dictionary. And there are 5 types of these somatostatin receptors. 80% of neuroendocrine tumors overexpress the second type, somatostatin receptor type 2. Octreotide, which we'll talk about as a treatment, has a really strong affinity for SSTR2. And then the Octreoscan and the DOTA-scan, which we'll also hear about later, also demonstrate presence or detect presence of this second somatostatin receptor. So just remember that there's a protein receptor. I like to think of this, many of my patients have seen me use this analogy, but like a lock and a key. So think of the receptor like the lock, and octreotide is like the key, and they have this special relationship where they can attach to each other. So just remember that analogy. We'll talk about this later today. So in terms of understanding your pathology, this is really one of the first key things to do in terms of net basics. So we talked a little bit about terminology already. There are special stains that the pathologist will use to examine a biopsy or a surgical specimen under the microscope. And these stains, the 2 key stains that identify a neuroendocrine tumor are synaptophysin and chromogranin A. And then grade really is a reflection of how rapidly dividing we think the cells are. We can determine that, again, by looking at the cells, how they look under the microscope, and by special stains. 2 key ways that we determine grade are something called Ki-67 and mitotic index. Those are both ways of determining how rapidly dividing the cells are. And that helps us put the grade into 3 buckets: grade 1, grade 2, and grade 3. Grade 1 and 2 are thought of as the slower growing, or also called well-differentiated neuroendocrine tumors, and grade 3 is a poorly differentiated or faster growing neuroendocrine carcinoma. Oh yes, this is a reminder to me. So often, we collaborate with many local community oncologists. Many of you have a community oncologist and an academic oncologist. As often as part of our second opinion, we encourage a second opinion pathology review. So I would say that there is expertise that is required for reviewing pathology. So that is a key take-home. This is just an example of what the pathologists look at under the microscope. And it sort of looks just like an abstract picture, probably for many of you, but the pathologist can tell the difference between these 3, between grade 1, grade 2, and grade 3, based on these special stains. So now, why does primary site matter? So once upon a time, in fact, in the not too distant past, even 10, 15 years ago, we really lumped all neuroendocrine tumors together. We thought they were all very similar, they were treated the same way, they were studied the same way in clinical trials, and it's really just been in the last 5 to 7 years that we've recognized that primary site does indeed matter. So they have different incidence rates, so number of patients diagnosed per year. They have different growth rates. They have respond to treatment differently, and are also now being studied differently in clinical trials. As an example, one of our first talks is on lung and thymic nets. This is a sort of previously forgotten subtype of neuroendocrine tumors, and is now really, there's an emphasis on trying to study that more exclusively. So primary site. So NETs can originate in almost any part of the body. I've listed a few of the common ones. So lung, thymus is an organ that sort of sits up in the chest above the lungs. The stomach, pancreas, small intestine. The small intestine is comprised of 3 parts, the duodenum, the jejunum, and the ileum. The appendix, which attaches kind of right at the junction of the small and the large intestine, and then the colon and the rectum. The small intestine is probably the most common primary site, followed by lung and pancreas, and then others. These are just some CT scan pictures of different primary sites, lung, pancreas, and small intestine, but as part of your primer, I'm gonna tell you how to read a CT. So imagine that these are bread slices through the body. We examine that your head is on this end of the screen and your feet are out here. You're looking up towards the body with the right is on actually your left and the left side of the body is on your right. So it's like looking at someone head on. And I think I have I don't think I have a pointer, but that's okay. So if you look at the lung picture, where the green markings are, that indicates where the mass is in the lungs. The sort of darker parts around that represent the normal lung. And similarly for the pancreas, the back is down low. We can see, again, where there's a green marking, evidence of a pancreas mass. And then for the small intestine, I think it's a little bit harder to see. There's another green marking there. But we may show some additional pictures of images throughout the day. So just remember that we think of these typically as looking at bread slices through the body. Okay, staging. So stage defines the extent of the cancer, where it has gone to, especially at the time of diagnosis. So more importantly, where is it and can it be removed? So stage and grade often get confused. So remember back to the pathology, that's the grade. That's how fast dividing are those cancer cells. Whereas stage refers to where is the cancer in the body. So we determine that by imaging. So those CT scans that you just saw, we can use MRIs, we can use an Octria scan, and we can use the new generation Octria scan, the gallium-68 dotatate PET-CT, which we're gonna have a special session on that a little bit later. These, again, are 2 pictures. The top image is a picture of a CT scan of the liver. The sort of bright circles in the liver, which is the organ on sort of the left side of that picture, indicate cancer spots in the liver. And then the bottom picture is a picture of an octreotide scan, which also shows sort of dark spots in the liver that represent cancer spots. So if you remember back to that net biology picture of the sort of lock and key, the somatostatin receptor and the octreotide, the Octria scan gives you a little injection of octreotide. It's labeled with a low dose of radiation and hones in on where those somatostatin receptors are and lights up like a light bulb where the cancer spots are in the body. That's what we're seeing on the Octria scan. Okay, another picture. This is the newer generation. You can see the clarity of these images compared to the Octria scan. This is the new gallium-68 dotatate PET-CT. And this also helps identify with that same lock and key principle where the cancer spots are in the body. Typically, Octria scan and gallium scans are bright in the well-differentiated neuroendocrine tumors. So again, staging. We have a classification for staging called the AJCC. It's the American Joint Committee on Cancer. They have developed a staging system for all cancers that you may have seen it called the TNM staging. It refers to tumor, node, and metastasis. And so that sort of lists these here as an example for pancreatic neuroendocrine tumors. And so stage typically is between 1 and 4. 1, 2, and 3 usually are localized, and 4 indicates that the cancer has spread from where it started. So again, just a reminder, stage does not equal grade. So hormones and functional neuroendocrine tumors. So we sort of split these into 2 categories. Either a tumor secretes hormones or it doesn't. And functional tumors are those that have, for patients who have symptoms from hormone excess. So carcinoid syndrome is the classic example. About 10% of patients with small intestine neuroendocrine tumors have carcinoid syndrome. It's due to the production of certain proteins, typically a protein called serotonin that can also be measured in the urine as 5-HIAA. It can cause symptoms such as flushing, diarrhea, bronchospasm, and heart valve disease, which we'll also talk about a little bit later. Pancreatic neuroendocrine tumors can also secrete hormones. They can secrete some other funny hormones such as insulin, gastrin, glucagon, and one called vasointestinal polypeptide, which causes diarrhea. And the symptoms from these are really determined by the hormone that's secreted. So you can imagine that if insulin is secreted, the blood sugar can be low. And then the large majority have non-functional neuroendocrine tumors, so do not secrete hormones. I'll mention just some blood and urine tests along with this topic, just because I think this topic can be very confusing. So hormone markers that are associated with symptoms include the following. So serotonin, insulin, gastrin, I won't go through that whole list. But there are other markers that are not associated with symptoms. We use these as a marker like one would PSA for prostate cancer. So it doesn't cause a symptom. Chromogranin, neuron-specific enolase, pancreatic polypeptide, they can be useful to complement imaging. So for example, if it's elevated at the time of diagnosis and you get a surgery or you get a treatment, we would expect it to drop. And so we monitor that as part of your surveillance. It can help us assess response to treatment. These blood markers are never solely used to make a decision. We typically partner that with imaging and how a patient is feeling. So a few parting thoughts before I turn the microphone over to Josh Mailman. So focus on understanding just a few key basics. There's going to be a lot of information today. Hopefully I've given you a few tools to help understand some of the talks today. Please write down questions on your cards. Please feel free. We'll have opportunity for lots of Q&A throughout the day. But these 5 key things, so I want you to remember a little bit about the nomenclature. So the key is neuroendocrine tumor, pathology, sort of those buckets of grade 1, grade 2, and grade 3, that primary site does indeed matter, stage, defines the extent of disease. We determine stage with using imaging tools. And then lastly, functional tumors are those that secrete hormones that cause symptoms. So I'm going to leave you with a few just thoughts and hopefully some hope. So net incidence is low. You've all been told you have a rare cancer. So incidence means the number diagnosed per year. So that's around 5 per 100,000. So we like to say you're not quite 1 in a million. But NETs are really not that rare. So interestingly, because many patients, it's a slower growing cancer, many patients live for quite a while with the well-differentiated neuroendocrine tumors. And so the prevalence is quite high, meaning the number of patients alive at any given time. It actually exceeds that of stomach and pancreas cancer, the adenocarcinoma type. So it's actually a much bigger public health problem than I think was previously recognized. Thus, we really need to study and do high-quality research and host events and raise awareness. So I think the positive that I want to leave you with is that we've had just a renaissance in research and drug approvals over the last few years. So back in the 80s, there was one drug. It was streptozotocin. It's an old chemotherapy that's not used very much anymore. And then octreotide was approved in the mid-80s. And then it wasn't until 2011, so a few decades later, that we started having new drugs developed. So we'll talk about many of these today. Everolimus and sunitinib in 2011 for pancreatic NETs, lanreotide in 2014, and then in 2016 we've had some other new drug approvals. But it has been really a tremendous time. I finished my fellowship in, can't remember now, 2009, and it's been an incredible time to be in the field, and I think a very optimistic time for patients. We've had so many new treatments approved, and I want you to feel hopeful about that today, and we'll talk about a lot of that. So I will end on that. I'd like to invite up Josh Mailman, who's also going to give you sort of his version of a primer of what patients need to know. So thanks for joining for this first talk today.